as we all know now, the combination therapy is a novel approach to really treating primary liver cancer. At the moment, we know, or at least we're aware of doublet or two combination therapies that are available. One of them is Atezolizumab plus Bevacizumab, and the other one is of the Durvalumab plus Tremelimumab. To be fair, they were never compared head-to-head, and they should never be compared head-to-head, because we have to really consume and use the energy and the whole economy of the clinical trial towards improvement towards novel ideas, and not necessarily to compare the ideas that we have. Nonetheless, quite importantly, that the better understanding of that data is evolving with time. If anything, three important variables are key in deciding how patients might be treated in that regard. Number one is the issue of the checkpoint inhibitors. All of them, without an exception, have a potential for anti-drug antibody, rendering the drug ineffective. If anything, data that came out from the Atezolizumab plus Bevacizumab data, or the IMbrave150 study, showed that 30% of patients could have anti-drug antibody, and this will impact outcome, as was reported a few weeks ago in Immuno-Oncology, where the hazard ratio will worsen quite a bit, enough that will be almost equivalent to the standard care of Sorafenib per se. The 30%, or even sometimes reported up to 50% with Atezolizumab, is a little bit nerving, because, for example, Durvalumab, the chance for anti-drug antibody is only 1.5%. The second point is, which is important, practical and important to remember, having an endoscopy to ensure that there's no varices is key. And please, 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 if you decide you want to give Atezolizumab plus Bevacizumab, which is a great therapy, make sure that your patient get endoscopies. Don't just say, oh, I'm not that worried about that patient, because you never know when the I'm not worried can become a problem. So please, endoscopies are key in that regard. Now, thirdly, truly, the issue is, and already kind of like I touched on a little bit in the question to begin with, is who are those patients? Because after all, we know liver cancer is a disease that will occur because of different risk factors or etiologies. The four key of them is hepatitis B, hepatitis C, fatty liver disease, and of course, fatty liver disease secondary to alcohol. So alcoholic fatty liver disease or non-alcoholic steatohepatitis. There is a certain understanding now that everybody does benefit from the checkpoint inhibitors-based therapy, like the Atezolizumab, Bevacizumab, or the Durvalumab, Tremelimumab. However, interestingly, we know very well that, relatively speaking, the Hep B patients might fare best, followed by the Hep C patients, followed by the non-viral patients. Data that was a little bit kind of intriguing to us, and I brought it up at the great debates as well, but this was more from ILCA, the International Liver Cancer Association, that happened in Madrid in September, where the patients who really were treated with the Atezolizumab plus Bevacizumab, the group in the UK, wisely and smartly, went on to a real-world data analysis. And they collected patients again on Atezolizumab plus Bevacizumab in real-world data to see how they fared in that regard. And interestingly, the 19.2-month median survival went all the way down to 15.74 months. Why is that? We're not really sure, but at least one attribute is that 50% of the patients on the Himalaya study, or I correct myself, 50% of the patients on the IMbrave150 study were hepatitis B, where in the real AB study from the UK, only about 30% were Hep B. And interestingly, that 15.73-month median survival for the IMbrave150, which is really now the number to go by with that further data, interestingly, is also 16.5 or about 16.5 in regard to Durvalumab, which ironically still 30% patient Hep B. So no doubt anybody with Hep B, if you have a rock solid all Hep B patients with the Durvalumab, probably the number will go way higher. But if we were to really compare to the best possible between all those studies, I would say that probably they are equal in regard to outcome. And of course, then you will decide based on the anti-drug antibody how nerved you are about that status that is especially dominant in regard to the Atezolizumab plus Bevacizumab. And of course, endoscopy that is required, of course, critically in regard to the Atezolizumab plus Bevacizumab.